Good morning, everybody. Our first question is about testing. Can you tell me more about the saliva test? I just lost my questions. When could we expect that to be available? How does it work? And will we need to go to a testing site to get it?
Hi, Hannah. I can start there, and Mark would definitely want your opinion on this. Given that you were on the front page of the Colorado this morning, congratulations. The saliva test, there are a number of different saliva tests that are available commercially, although there are some issues surrounding their sensitivity and specificity with regard to detection of virus. Mark Zabel, who I think can comment next, is a person who's been working on the test that's being developed at CSU. One of the big issues in terms of saliva is not so much that it's doesn't detect as well as nasopharyngeal swabs. It's more surrounding the process that it needs to go through in order to get FDA approval and then become widely available. So currently, most commercial laboratories are not conducting saliva testing. And that's one reason why at this point, you couldn't just go to your doctor and do a saliva test, at least in most states. But that is likely to change. So I will let Mark take it from here and comment on his knowledge of this.
Thanks, Nicole. So yeah, so my lab's been helping to develop a saliva-based test for testing CSU students in tandem with that wastewater testing that you all may have heard about already. So this is efforts led by Dr. Carol Willis to monitor the wastewater coming out of our buildings on campus. And so when we see higher levels of wastewater testing for SARS-CoV-2, the idea is that we will go in and then test all the individuals that inhabit those buildings, dorms, classroom buildings, et cetera. And this strategy has worked really well so far for CSU in terms of keeping ahead of spreaders. So it's likely that this signal in the wastewater is a sentinel for potential spread. And if we can get in there with a saliva test, good thing about the saliva test is that it does seem to mirror NP swab data that we've been collecting very closely. So right now we're going through that validation stage, comparing our test with an FDA-approved test. That's vital for being able to use it on a large scale. I can tell you unofficially that that is going really well, and I think we'll have enough validation data by the end of the week to move forward. So far, it looks great. I'm very confident that we will be able to roll this test out on a wide scale, probably starting this week. But again, we are not the FDA-approved test, so we're comparing it to that more traditional test where they take a sample using a NP swab. And so we have to make sure that we can detect all of the samples that test can detect. Again, we are not an FDA lab, so we can't even say, for example, that we have positive tests, right? And we don't even call our test a test yet. We call it a screen. So right now what we do is when we have a test that looks positive, we don't say positive, but we call that a follow-up. So we can contact that individual that provided that test, that sample, and say that they have to follow up with an FDA-approved test. What we hope to do is get emergency use authorization for this test, and after our validation and we have that data, we will start that process of applying to the FDA for that. Since it is emergency use, it is expedited, so we hope that goes fast. And if so, then we can start using this test exclusively in place of the FDA-approved test, and then start using it on a wide scale. If we do that, then other individuals can use our test for EUA, for emergency use authorization, and that's when the test might become available to the general public. How long that takes, I have no idea because this is the first time I've gone through the process. I do know that we've been told that it is expedited. For example, the veterinary diagnostic lab at CSU is an FDA-approved, CLIA certified lab to do these tests now. They had a little bit more infrastructure in place to really expedite their process. And it was very quick and on the order of days to weeks. I hope that is true for our test too, but at this point, I'm just not sure of that process. But once we do get the validation data, we apply for that authorization, and then other labs can use that, pick it up, and start offering testing to the general public.
Thank you both. Next question. We keep hearing about these rapid tests to detect the virus. The federal government has given them to nursing homes around the country. Why aren't these being used in settings like airports or for visiting people in residential care communities?
Thanks, Hannah. I'll start. So this is something that we're very interested in my lab, because we've been doing the statewide COVID screening program throughout residential care communities in Colorado. This definitely has the potential to be a game changer, this rapid test, and they come in various forms. Most of the ones that you hear about in the media that everyone's super excited about are these kind of 15-minute tests that are very inexpensive. But one of the problems is that the ones that are available right now commercially have only been tested in people that are symptomatic for COVID-19. And we really don't know much about how these tests perform in asymptomatic people, which is where really the most potential to be a game changer is. You know, for example, the person who wrote the question in being able to screen people at airports, for example, you know, you could certainly imagine after you go through TSA screening for, you know, explosives and other safety, you know, threats, you would then go through a biosafety screening process where perhaps you would have one of these tests before you board a plane. This is the kind of thing that could be done on a wide scale, probably and quickly, but there needs to be a lot more research done about how well this test detects people who are positive in a large number of people that have no symptoms. And that's really where things are stuck right now, although we are hoping to begin a study where we do side-by-side testing of these types of rapid antigen tests with PCR in asymptomatic people in order to begin to answer those questions.
And I was just going to add a few thoughts, because we had an outbreak and we magically got these on the week of an outbreak. And so we were able to use it in that setting, but because a lot of these patients were symptomatic, the positive was more reliable for us. And because of these false positive results that we're seeing across the country, I think the state of Nevada actually pulled these from facilities, not allowing them to use it, because there's a lot of negative effects that come to residents. If they have a false positive, you think it's an outbreak, people are isolated, different things. So I do think, you know, I'm hopeful that they get better, because it would be an amazing tool to be able to have these at a facility where we could rapidly screen family members and allow for visitation. And so I'm hopeful that they will continue to improve. We're just being very cautious, and we are verifying with the nasal swab when we have been using these recently, just to make sure that we are having accurate, you know, using the gold standard to make sure we have accurate results. So.
Thank you both. Next question. Herd immunity is discussed in the media as a goal, but doesn't that mean that the majority of people in the United States will have to get the disease? This shouldn't be a goal, should it?
Okay, I'll start with that, and I'll try to get my video going here. There we go. So herd immunity has a lot of different parameters, and herd immunity means that you get enough people in a population or enough animals in a population immune so that you don't have efficient spread of any particular disease. And that immunity does not have to be through infection. It can also be through vaccination. So we've got two of those dynamics working right now. We're waiting for a vaccine. We don't have it available. We're hoping that there will be effective vaccines available soon, but we do have spread of the disease among a human population, and it spreads sometimes quickly in parts of a population, less quickly in other parts. If we look at states throughout the US and look at the population density of various states, Alaska is the least densely populated state that we have, 1.2 people per square mile. But that doesn't mean that they're evenly dispensed throughout the whole vast state of Alaska. In the metropolitan areas like Juneau, Anchorage, a few others, then it's a lot more dense in those particular areas. Whereas in the outback places, tundra places where there may be a few villages, you've got a lot less density. So the herd immunity is going to be different. If we look at Wyoming, 5.85 people per square mile. Colorado, about 10 times that, 55 people per square mile. And then if we look at New York, the state of New York, 27,000 people per square mile. So we've got a huge variance in the density of the populations that we would be looking at. Currently, the only way that we're going to achieve herd immunity is through people becoming infected and then becoming immune. But that is not the way that we want the overall herd immunity to be established. We're very optimistic that in the near future, there will be vaccines, and not just a vaccine, but vaccines, different choices, different options available to vaccinate the public. And then this will really speed up the overall herd immunity, and not just in our country or our state or our town, but worldwide. So this is something that we have to look at, we have to keep up with, and view that from the standpoint of stopping the spread, slowing down the spread. And then if there are less susceptible people, whether it's through recovery from infection or whether it's through vaccination, the spread of the disease will slow down through what's referred to as herd immunity.
Yeah, thanks, Bob. I agree completely. There are two basic ways to get herd immunity, right? One is vaccines, like mass vaccination. The other is natural exposure. If you go the natural exposure route before we get a vaccine, you're basically looking at herd fatalities, right? So you're going to have a lot of people that are susceptible to the disease that whose immune system won't be able to fight it, and those individuals will succumb to the disease, while other people with healthier, more robust immune systems, younger individuals, for example, will probably survive and contribute to that herd immunity. But that's not what we want to do, right? Because in order to get herd immunity, you've heard percentages of around 70% of the US population. And we know that the fatality rate is still hovering right around 3%, just a little bit lower than that. But if you do the math, that's a couple of million people that would need to die from COVID before we would reach that 70% herd immunity. So our best bet really is to keep everybody safe and keep the spread to a minimum while we develop vaccines, which will allow immunity to be developed in a safe way. And how do we do that? It's the simple stuff that we've talked about, right? It's the masks, it's the social distancing, it's the washing your hands, and it's not touching your face. Those are the simple things that we need to do to prevent as many transmission events as possible until those vaccines are in place.
And this is Rebecca. I totally agree with both of those statements. Our frail populations, the people, surviving the outbreaks are happening in care facilities, and we are so dependent on the rate of community spread. So anything that we can do to keep that community spread to a minimum is certainly helpful for the frailer populations in our community. And somebody did put a good question into the chat about, are we even sure that once one gets COVID that they will not be able to get it again? And so we don't know that, right? Like there are some case studies that had come out of China, I think, that were showing that people have been reinfected. It was a little less severe course of the illness, but I think that's still out there, and I'm sure maybe the researchers can have more input on that. But I think, you know, we don't know that for sure, that this isn't going to be like flu where we're trying to guess which strain is coming through every year and those kind of things. So, you know, I think waiting for vaccines and those kind of things is a much safer way for herd immunity than just letting the population get sick. So thank you.
Thanks, everyone. Next question. It says, I am a grandparent raising my grandson with special needs, and I am in a high-risk category by having COPD. He attends school 5 days a week so that he can get support from his teachers. They are a small group of kids in a class of their own. When we got a call that one of the children in the class was showing COVID symptoms, we were to keep him home for 2 days and report if he has symptoms. If he does not, we're supposed to return him to school after that 2 days. This does not seem like a good protocol. Is the incubation period for COVID not 7 to 14 days? We feel like we are being put in a precarious state. So what can you advise for our older adults that have young children at home returning from school and putting us at risk? And does 2 days of quarantine seem expectable to you?
All right, I can try to handle that one, start off with that. And I would say that you've touched on a subject that we're all certainly worried about. I mean, I have young children at home and I worry about this as well. So it's a really great question. You know, I don't know the scenario completely. So typically a high risk exposure per the CDC is you're gonna have, you know, you're less than 6 feet apart from someone and you're in a room with them for greater than 15 minutes, not wearing a mask. So that is considered a high risk exposure. And that's why we mask, because if multiple parties are masking, that decreases your exposure risk. So if that is what was happening, certainly it is reasonable for people to quarantine at home. There are multiple things going around in the community still right now that can cause similar symptoms to COVID. So I don't know if the 2 days came from potentially them trying to get the student swab to make sure that it wasn't COVID, because there you can do viral panels and look for other things as well that could have caused those symptoms. So I don't know if that was the thought process behind the 2 days. Typically, if you do have a high risk exposure though, because that quarantine period is 14 days, because that you are correct, that's the incubation period. So once you have had that high risk exposure, you are expected to stay home for 14 days. So does anyone else want to speak to that?
Yeah, thanks, Rebecca. I totally agree. Incubation periods at least 14 days. I frankly would, and I'm not a medical professional, I'm a basic researcher, but I would argue that this grandparent is absolutely right. 2 days is wholly inadequate. And I would say that on exposure in a classroom like that, depending on if the kids have masks on, if they do not, that is definitely a significant exposure. They're in classrooms probably all day with one another. And so 2 days without symptoms is not adequate to determine whether or not that individual is going to be positive 14 days out. So my advice, especially if these children spend time with grandparents who are in high risk, that they do quarantine at home and get a test. And if it were me, I would have my child tested as soon as they get home, and even a week later before I would feel comfortable sending them back to school.
Okay, thank you all for that. There is a study taking place at Washington University that is testing the MMR vaccine in hopes that it strengthens the immune response to viral infections. Do the panelists know anything about the potential of the MMR vaccine to possibly immunize the population against COVID?
Thanks, Hannah. I'll start. So there is a trial going on using the MMR vaccine, and the kind of purpose is to hopefully create a bridge while we're waiting for a specific SARS-CoV-2 vaccine. The reason why these researchers feel that the MMR vaccine may be somewhat protective is twofold. One is it's a modified live virus, which means it consists of a very weak but live virus, which does create an immune response that can help fight off other viruses to some extent. So it's kind of a general immune response. And the other thing is it does seem to create some antibodies, which are the protection that your body creates after a vaccine, that cross-react with the virus that causes COVID-19. So the hope is with the MMR is not so much that it will prevent SARS-CoV-2, although I suppose that's kind of the gold ring that everybody would like to see, but that it would lessen the effects of an infection to the point where it would be a much milder infection. And this becomes a pretty big deal in populations like third world countries where MMR vaccination is not routine. And it may be something that they can use in the interim to protect healthcare workers to prevent them from getting sick, which again is another strategy to sort of vaccinate those who will care for the people that get sick from COVID in hopes that that can help people with COVID recover. So it is a strategy that's being looked at, but again, won't replace at least it's not expected to replace a specific SARS-CoV-2 vaccine, more like a bridge to wait until we can actually see a vaccine be widely distributed throughout the world. And that's kind of what I know about it. I don't know.
Bob, did you want to weigh in? I'm happy to weigh in as well. So yeah, Dr. Earhart is absolutely correct. What they're looking for in these vaccines, and a similar strategy is being tried with a tuberculosis vaccine, a common tuberculosis vaccine. The strategy there is it's not going to be specific for coronaviruses, but it generally increases your immune response. And they're hoping that, as Nicole said, frontline workers, if they get these boosts, these vaccine boosts, it helps to kind of stimulate their immune response that will help prevent the SARS-CoV-2 from establishing an infection. And that's basically it. Interestingly, though, Mary Jackson, Dr. Jackson here at CSU, she's a world famous tuberculosis researcher too. She's trying a similar thing with that same tuberculosis vaccine. But she's modifying it a little bit to express parts of the SARS-CoV-2 virus, right? So that would, if it works, would give you specific immunity against COVID. That's a similar strategy that's being tried in a couple of these other vaccines that are currently in phase 3 clinical trials, using a different organism that's less pathogenic, and it's modified to not cause a disease, but you can put parts of the SARS-CoV-2 virus into it, and then it will express those parts and hopefully stimulate an immune response against COVID. So there's a couple of vaccines that are currently using that strategy. It's a pretty common strategy for vaccines that we all use currently. And so we hope that that will work. One concern I do have about that strategy, and I'll be interested to see what the data points out, is we know that young children are less susceptible to severe disease than older individuals. And that is a little bit counterintuitive because really young individuals' immune systems are still developing. But that's a clue. We know that part of the disease process, the pathology of COVID, is an hyperactive immune response in your lungs, and that causes some of the more severe diseases. And my fear is that if you're using a vaccine that kind of generally stimulates your immune response, that could exacerbate, that could make that immune response against SARS-CoV even worse. And we know that that can make your COVID outcome even more severe. And so I hope, that doesn't happen, but we do need to keep an eye on potentiating that immune response that might hurt rather than help.
The virology that might help explain some of that phenomenon that is being explored is that usually multiple viruses do not infect the same cell. And so that if you're giving the MMR, which has modified live virus in it and relies on that modified live virus to stimulate the immune response, that might then preclude some of those cells from being infected by the SARS-CoV-2 virus. So that could be an added effect of that. The enhancement of the immune system, sure, I think that's part of it, as both Mark and Nicole mentioned, and probably a few other things. But you wouldn't get the same assisted effect by using a killed vaccine. So normally the influenza vaccine injections that you get are totally inactivated, killed virus, and you wouldn't expect that to help your response to SARS-CoV-2.
Thank you, guys. Next question. When they say that diabetes is a risk factor, is that for all diabetics, even those who control theirs with diet only? Does this refer to both type 1 and type 2?
Okay, this is a good question because there are different mechanisms of action. So I looked into this, and with type 2 diabetes, CDC's statement is definitive that it increases the risk of severe illness from COVID-19. But for type 1 or gestational diabetes, the word may is added, that it may increase risk of severe illness. So meaning it may depend on other health factors, and also more information is being gathered. CDC doesn't include information on borderline or pre-diabetes though, so there's not much information available on that. And I did want to mention that recent research from the University of Michigan indicates that high blood sugar may trigger worse outcomes. So they make the argument that improving glucose control then may improve outcomes and reduce secondary infections. So I'm going to put a link to that research in the chat box and hand it over to Rebecca. Thank you.
Oh, that's great. Thank you. Yeah, I wonder if the type 2, like they could make a more strong statement on type 2 diabetes simply because there's other usually comorbid conditions too that are associated with that. So like a lot of people will have obesity and hypertension too associated with that disease process. But I think what's true with diabetes in general, no matter what your infection is that your glucose control is really gonna impact your ability to fight off an infection, right? So if you're not having good glucose control, you are definitely going to be more susceptible. So I think it's really important for people to continue working with their primary care provider to really find out what your goal is for your glucose readings and try to get good glycemic control. The other thing is looking at those comorbid conditions too. So if you have hypertension, obesity, that can also impact your response to a COVID infection. So, all of us should be, myself included, we should all be working on exercise and diet and those kind of things that can continue to keep us healthy during this time period.
Thank you both. So got a timely question next. What course of treatment was prescribed for President Trump? And is this something that will likely be a cure? Isn't the antibody cocktail not FDA approved?
All right, I will do my best to try to answer this question. So I'm not a hospital doctor, but I do know that he did get, a lot of times when people are entering the hospital at this time, if they have COVID and they're having increased oxygen requirements, they usually get a course of IV dexamethasone, which is a steroid. And the whole thought is they use those, with other types of respiratory infections to decrease inflammation. He also got IV remdesivir, which is an antiviral, and those are being pretty routinely used, is my understanding, at our local community hospitals for patients who are coming in with COVID infections. the thing that he got was that everyone's really been talking about is the monoclonal antibody, which is not FDA approved. You're right. So that's not something that's readily available to the community right now. And it's still in clinical trials, but they are doing that trial through UC Health. So if you were to go to the hospital, enroll in that trial, there is a possibility that you could receive the monoclonal antibody cocktail that he got, but it also, you may not, because there's always the placebo wing, meaning the medication that it's a placebo, meaning it's not the actual medication. So he was able to get it through like a compassionate use, is my understanding, which the researchers in the group can probably talk to what that entails a little bit better than I can. But the big thing I would say is that it's not a cure. All of those, you know, the remdesivir and stuff, those have been shown to decrease the duration of illness. It's not a cure for COVID. So the whole hope is that we can decrease severity and the duration of someone's illness, but it does not, you know, the masking and washing your hands is the things that are going to protect us the most. It won't solve that for the community. So.
Okay, and I'll add a little bit to that, but not very much. I think Rebecca covered it really well from the information that's available. The antibody that he was given, the monoclonal antibody or antibodies, will help your immune system or help your body react to the virus that you're infected with. The antibodies are those that will actually combat the virus right immediately because they're already formed, they're already prepared and then administered and then can inactivate the virus, and you're not waiting on your own immune system, which may take 3 to 5 days to really get a good start and 7 to 10 days to be quite effective. So what that does is the monoclonal antibody or a plasma antibodies from people who have recovered from a particular disease just gives your body a jump start on effectively combating until your immune system can take over. And it appeared that probably helped. We don't know, we don't see all the details, but anyway, that's the way I would look at it.
Yeah, I agree. Just quickly, this cocktail of drugs is really interesting. The dexamethasone is a steroid that really has wide-ranging effects, not just on the immune system, but it's generally immunosuppressive. And I think they're giving, and that's usually given to COVID patients that are experiencing a significant cytokine storm. So that's that increase in immune response that actually is starting to damage lung tissue. They may have decided to give the president that as an early treatment to avoid that hyperactive immune response. But if you do that, then that does dampen your immune response, and it could increase the time that that virus stays around, right? So you could be infected longer if you suppress your immune system. I think that's why they're giving the president antivirals too, and that monoclonal antibody. To me, it reminds me of giving patients that have undergone transplants immunosuppressive drugs so that you don't reject the organ, but you also have to give them antibiotics while you suppress your immune system so you don't get another infection that can also harm you. And I think this regimen that the president was put on is akin to that, right? They try to lower the immune response so that it doesn't get lung damage, but then you have to balance that with, you're not going to be able to eliminate the virus as effectively with your own immune system. So you have to use antivirals. And then they're just throwing in this monoclonal as well, really just throwing all that against the wall and hoping something sticks, honestly.
I love the way you describe that. That's a really great way to describe it. And it's really interesting because at the beginning when COVID first hit, we were told don't use steroids, right? Because it prolongs the viral replication. So yeah, it's interesting how the treatments are already shifting. My understanding is that when they do give the steroids, it's a course over 7 days, and then they stop the steroid after that. So yeah, that's a great way to describe it.
So speaking of the immune response, should we be taking Emergen-C or elderberry, zinc, or echinacea to boost our immune systems?
There we go. Well, as you can imagine, it's really challenging to set up clinical trials that are aimed at answering those questions, since COVID is new and the response to it varies considerably depending on individual factors that are still being figured out. So solid evidence is hard to come by, and it's either often unavailable or the words may be beneficial are used. So the short version with vitamin C, echinacea, and elderberry, there's no verified information yet. With zinc, it's in the maybe category, but it's still early days, and research is still needed on that. I do want to mention, I'm going to put a link in a hyperlink in the chat box to more specific information about all four of those, because there are some research documents that tie to all four. But so FDA and the Federal Trade Commission have taken action against companies that marketed their products with unsubstantiated claims. So if just because you see it on a box doesn't necessarily mean it's true. They try to get that off the shelves when possible, but apparently that doesn't always work. And really the bottom line is maintaining healthy habits in terms of nutrition, sleep, and physical distancing is still the best strategy. But stay tuned, work is being done to evaluate the possible benefits of some of these dietary supplements. Thank you.
Thank you, Marissa. So our next few questions are about air quality and air transmission. Should we or can we wear masks while exercising? Are gyms safe if I am in a high-risk group?
We're having some trouble hearing you, John.
How about now?
Good.
Apologies. So both of these questions are a little bit loaded, so I'm going to try and unpack them. Should I and can I wear a mask while exercising? The answer is yes, you should wear a mask while exercising indoors if there are strangers around who I would say are outside your bubble. But the loaded part is you need to know your body and know whether or not that mask is impeding oxygen flow. This can present a second danger, because if you don't get enough oxygen to your body, you're going to put yourself under respiratory distress. Personally, if I were indoors in a gym, I would always wear a mask while exercising because it can lower your risk. And the second question, are gyms safe if I am not in a high-risk group? Well, that all depends on your risk tolerance. So that really depends on you personally. How do you feel if you were to get COVID? Because gyms are a higher risk environment. You emit more aerosol out of your body when you breathe more rigorously. You emit more aerosol also when you talk and when you shout, and then you emit the most probably when you shout and sing. Now, gyms don't have a lot of people shouting and singing indoors in close proximity, but they do have a lot of people breathing vigorously. And we do know that more particles that can contain the COVID virion can come out of your body when you are breathing more vigorously. And so for that reason, and due to the proximity of people within gyms to each other, gyms are a high risk category. Gyms have taken a lot of steps to lower risks indoors by increasing ventilation rates, by requiring everyone to wear masks, by requiring distance. All of those precautions are been shown to be effective at reducing your exposure. So it's really a combination of your own risk tolerance, and I would say finding out what steps your gym is taking. Personally, I would not exercise in a gym if there wasn't a mask mandate for everyone inside.
John, could you go ahead and add on to that the proper way to wear a mask, because walking around in stores, in the general public, even in gyms, you see people that have a mask hanging around their neck, or maybe covering their mouth but not their nose, and then maybe half the people, or a little more hopefully, will have it over their nose and mouth. Could you talk about that too, please?
Sure, I'd be happy to. And that relates to another question we have on our board here about some people saying that masks are not effective as a preventative measure because COVID is spread through aerosols. It's true that COVID can be spread through large respiratory droplets, the kind of thing where you're close talking with someone, you feel a little spit on your face. That's what we call, respiratory droplets. It also is spread through aerosols, which are smaller particles that come out of your body that you can't see. Both of those are important for COVID transmission in air. The greatest risk is when you're in what we call close respiratory contact, which means within 6 feet and talking at someone, because you're expelling air out of your body towards that person. And so in that case, both the aerosols and the droplets can reach a person. I can tell you definitively that masks help reduce your risk of exposure for both of those modes. The mask stops the jet of air coming out of your body, and so the droplets don't have anywhere to go. It stops the droplets, and to some degree, it physically filters out the aerosols, the smaller particles that might, that might linger in air longer. However, it's very important to wear a mask correctly. And so what does that mean? The two things that are most important is that you obviously cover your nose and mouth. The second thing is that the mask have a good seal. That's probably the thing I see most out in public, is that people wear masks and they're really just loosely fitting on the face. In that regard, the mask will only stop the large respiratory droplets. That's still an important transmission risk reduction. So understand that masks, even if they're loosely fitting, have some efficacy. But a mask that has a good seal on your face, where when you breathe out, it doesn't fog up your glasses. You shouldn't be able to blow out a birthday candle, with a mask on. And then the last thing, this is the last test, if you really want to know if your mask is fitting. If you breathe out quickly and you're facing yourself in the mirror, do you blink? If you blink and you're breathing out quickly, that means that most of the air is going right up the side of the mask, not through the mask, up the side and hitting your eyes and making you blink. That means that your mask probably isn't fitting as well. Most masks that I see out there don't have great seals. And so you need to work to either tighten the mask onto your face or find something with a stronger nose bridge, that wire up here that produces a good seal on your face. If you do those things, you can lower your risk of transmission and infection, because the mask stops particles coming out of your body. It stops particles coming into your body by up to a factor of 10. Really significant risk reduction for masks. You should always be wearing them.
Thank you, John. That's some great information. So moving to a very Colorado topic, wildfire smoke. It is so bad that it's not good to go outside. How do I deal with the mental health aspects of being on lockdown and being locked in because of the smoke?
I think this one's probably for me too. Yes, wildfire smoke is bad for your health. And it's been very bad in the Front Range for over a month now. A couple things about that. Yes, while it's plausible that exposure to wildfire smoke can potentially make you more susceptible to the effects of COVID-19, because COVID-19 likes to live deep in your respiratory tract, and wildfire smoke is a respiratory irritant. Outside of the COVID realm, you should never be breathing in wildfire smoke. Because it is bad for you. And it's been shown that increases in wildfire smoke levels outdoors can affect anyone with a pre-existing respiratory or cardiopulmonary disease. So if you're susceptible to stroke or heart attack, or if you have asthma or COPD, all of those diseases can be made worse by exposure to wildfire smoke. Rule of thumb, if you can't see the foothills from Fort Collins or from within 5 miles, you should not be outside in that weather. There are resources, and I'll put them into the chat, for finding out what the levels are, and they're pretty good. Both the EPA and the Colorado Department of Public Health and Environment, and even now your local weather app, will give you warnings about when air quality is poor outside. But if you find yourself not paying attention to those and you can't see the foothills one day and it's not a blizzard, then the wildfire smoke is too bad outside for you to be there. Absolutely do not exercise outside. That's, you know, my second point. Can you be outside for 30 minutes with a mask on if it's, you know, a yellow or orange day? Sure, that's probably not going to cause you too much harm, but you need to know your body. And so if you're an asthmatic or someone with COPD, you can make your disease a little bit worse even with a short-term exposure, because being outside for, you know, 5, 6, 7 hours in that weather is akin to taking a few puffs off a cigarette, and we all know what, you know, what that does to your body. Let's see. The other thing is about masks. Most cloth masks that we're using to protect ourselves from COVID-19 cannot protect you from wildfire smoke, because wildfire smoke is at a size range that it's hard to stop it. The smoke particles are smaller than the COVID virion itself, and they tend to get through the mask more efficiently. The only way to protect yourself is really with a high efficiency mask or with an N95. And of course, N95s are hard to come by. You can find them, but you have to do a little bit of digging. An N95 will protect you from wildfire smoke. A cloth mask will not.
Thank you, John. I wanted to just add a little bit about the mental health piece and maybe kind of follow up with some really good points that all the panelists have been making. I think one of the things to remember is that a lot of what's going on is kind of on a continuum. So when we want things to sort of COVID be over, we've talked about how it's probably not going to be this black and white, it's ending and now everything's safe, that every decision that we make every day is sort of a function of our comfort with risk and sort of what we're willing to do. And in terms of trying to preserve your mental health, if you're trapped inside, either due to the pandemic or due to wildfire smoke, it really is little things that you can do. So if you want to set up a desk or a chair or a workstation where you are not opening your windows, but opening your blinds. I mean, I know that sounds silly, but make sure that you're still letting as much nature kind of into your house so you're not feeling trapped. There have also been lots of people in the field of exercise who have been recording and doing yoga outdoors, all sorts of exercise classes in nature. So I know what people would rather have is the opportunity to physically be out in nature, but if you're finding on those days that you can't go out, that you're missing that, on YouTube there are a ton of videos. If you can put it up on a big screen and at least have your blinds open, just try not to get sort of in this black and white of if I can't be outside, I can't do anything. I think one of the things that we know happens in psychology is when anxiety goes up or when depression goes up, our motivation goes down. And one of our shortcuts when motivation is down is to do sort of this black and white thinking of, if I can't do what I want, I'm not going to do anything. Because that's kind of a shortcut and doesn't take as much of our resources. But really be vigilant that everything you decide to do on those days that you are inside, again, either due to the pandemic or due to what's going on in terms of air quality, contributes to how you're going to be doing that day and every day past. So I think we've had quite a few panelists talk about having good nutrition, making sure that you're getting sleep, and really being very active in how you're planning your day. So don't just let the day unfold without any structure in the morning. Try and say, I'm going to sit in front of a window today with the blinds open and do a puzzle because that's something I enjoy, or I'm going to make myself something healthy and watch a nature show on TV. So I know for a lot of people, it's not what we want to hear because it's not what we would like to be doing, but I think it's really important to be very vigilant about how you're thinking and how you're making decisions, and being very effortful and how you're planning your day and trying to take as even little pieces of nature, even if it's on a screen or outside of a window, rather than losing that altogether.
Thank you, Deanna. We only have a couple minutes left, so if you have any questions, put them in the chat and we'll try to get some answers to you after the fact. But our last question that we have is kind of a two-part question. It says, why are COVID cases increasing in Colorado right now? And what is the prediction for numbers of cases in the next 3 to 6 months?
Hi, everybody. I think Dr. Earhart had to leave for a little bit early, so she asked me to help with this question. I would say that there's a couple of reasons why the COVID cases are increasing. One is certainly that we're doing more testing. That includes both CSU and CU Boulder, and we're contributing to the total number of tests that are running daily, as well as to the positive cases that we're finding, right? So you know that if we test more, we find more cases, which is a good thing. But we are also starting to enter flu season, and so and I would just say that the increased testing is not the only reason we're seeing more cases. We are also watching hospitalizations increase. That is a lagging indicator that we are seeing increased transmission in Colorado as well. So it's not just contributed to more testing. And I would just caution that we are likely to see this continue to increase as it gets colder, as flu season starts, as we become more indoors, as we have comorbidity with flu. Expect that those cases will increase, as well as hospitalizations and unfortunately fatalities as well. I think a third component to those rises is also quarantine fatigue, right? So we've talked a lot about mask wearing, how to do it properly, and how to do it safely, interacting safely in public. But you know, it's a long haul, right? We've been doing this for 7 or 8 months now, and we're all getting a little bit fatigued from this. I'm also hoping that for some people, this is just becoming routine, so we do get better compliance. I think it's a mixed bag. But yeah, I would just say that there's a couple of factors contributing to the increase in the number of tests, positive tests, and we should just anticipate that that's going to increase as we enter flu season.